to our next speaker, Dr. Rachel van Leeuwaarde. She is an endocrinologist and clinical epidemiologist at the University Medical Center of Utrecht in the Netherlands. She is the chair of VHL Multidisciplinary Tumor Board and the coordinating VHL specialist at the UMC Utrecht. Her research is directed to epidemiology, quality of life-related studies, and novel therapies for genetic tumor syndromes, with a special interest in VHL and MEN syndromes. She is a leading investigator of the prospective Dutch VHL cohort, which involves a national prospective registry and biobank. So with that, welcome, Rachel, and the floor is yours.
Well, thank you. Thank you for the kind introduction. Let me share my screen. This one. Yes. Can you all see my screen now?
Yes, perfect.
Perfect. Oh, this is actually the first one. Thank you for the invitation again. Quite a challenging topic, quality of life, totally different from the other presentations we just heard. What a very challenging task. I'm going to talk with you about new insight and challenges regarding quality of life and VHL. I have some poll questions in my presentation. Just want to check if the poll is working. So this is not a very serious question, but do you know the painter of this very lively household? I picked this one. Of course, it's a Dutch painter because I'm from the Netherlands. And it's a lively household with which really illustrates quality of life, a good quality of life, different age groups. People are making music here, laughing. So who do you think the painter is? I think people who know a lot about art probably know. Is it Vincent van Gogh, Rembrandt van Rijn, Jan Steen, or Johannes Vermeer? Oh, wait a second. And I hope that I can see the results soon. Yes, okay, well, I see some results here already. Most of you think it's Rembrandt van Rijn, probably because he's one of the most famous painters, but actually it's Jan Steen. I think that most people didn't know that. Jan Steen is a very well-known painter in the Netherlands as well, same time period as Rembrandt and Vermeer, and he is known for painting very lively households and a very, very nice painting. This one is actually in Amsterdam in the Rijksmuseum. So let's start with the presentation now. Let's see, I can't move forward. And maybe it's because of the poll. Okay. Yes, all right. So we'll talk about the psychosocial impact and VHL. What do we know up to now? And what do we know from other hereditary tumor syndromes? What are the challenges we're faced with, and what can be future directions? So the next question is the following: how many studies do you think, does the audience think, have been published on quality of life and VHL? Is this 5 or less, between 6 and 10 studies, 10, 15, or over 15 studies? So I wonder what the audience thinks about this. Yes, I'll see the answers here. I don't know if you also see the answers, but 55% of the audience says that 5 or less studies on quality of life. Only 2% think it's more than 15, and in fact, it's true. I could only find 5 studies regarding a quality of life related topic and VHL, which is not a lot. And I think it also illustrates that this is a topic that is quite underexposed. Trying to move on to the next slide.
If you click on your PowerPoint, it should advance.
Okay. Yes, okay. So what do we know? The first study on quality of life and VHL was actually published from a group from the Netherlands by Chantal Lammens. 123 people participated, 68 carriers, 16 patients at risk, and 39 non-carriers. And the impact of VHL on quality of life was assessed, but also VHL-related worry and distress. And the authors looked at which variables would lead to heightened levels of VHL-related worry and distress. It was a cross-sectional study. 3 validated questionnaires on quality of life were completed by the participants. Also some other small questionnaires which were actually not validated. But the results were as follows. 50% had high scores of distress. And carriers had worse general health perception and worse physical functioning on the SF36 health questionnaire. And interestingly, we found that female gender, but also experiencing death of a close family member during adolescence would lead to higher levels of distress in patients on a multivariable level. So the same study, but now only in partners of patients with VHL. And here we found that in partners, 28% had clinically relevant levels of distress related to VHL. The distress was also related to partners' levels of distress and younger age, but also lack of social support was associated with this heightened levels of distress and worries. So I think these were quite good performed studies and illustrate the levels of high distress in our patients. So if we move to Australia, in 2015, a study was published in 15 patients and 8 people who cared for patients. Again, a cross-sectional design. It was a qualitative study in which the psychosocial difficulties experienced by families affected by VHL were assessed by interviews. And what was concluded is that people found that there was a lot of uncertainty about future tumor development. There was quite some frustration regarding the need for lifelong medical screening, strained family relationships, difficulties communicating with others about VHL, limited career opportunities, and financial burden. And it was quite difficult to make good decisions about childbearing and difficulties assessing medical and psychosocial care. And I think those of us who have patients in care with VHL recognize all these themes. So this was quite an illustrative study from Australia. 2018, a French study was published in which 24 patients were included. Patients were actually recalled. They all underwent an hemioglobinoma surgery from 1999 until 2015. And they were offered questionnaires during the recall procedure and also during genetic testing and when they got the results from the testing. And they used 4 validated questionnaires. The conclusion was that there was no negative psychosocial impact of VHL testing in patients who had a previous history of a CNS hemioglobinoma, which is quite assuring, but it doesn't say anything about long-term surveillance if patients have VHL. All right, so this is actually the last study on quality of life from the US, published this year, 26 carriers, and the study was about young adults' attitudes towards dating and decisions related to disclosing the diagnosis of VHL to a dating partner. I think a very relevant topic. And the study was done with semi-structured interviews. So the results were as followed. Lots of the participants had quite a bit of fear of rejection because of VHL. And many had experienced negative reactions by partners in the past. Partners were unfamiliar with the disease and perceived it exceptionally serious. But on the other hand, disclosure of having VHL also strengthened the relationship and deepened trust. So that is a more positive side. But also we can see the burden and the impact it has on young patients with VHL. The participants stressed that it is very important to have talks with peers with VHL, and also that patient-centered support is offered from healthcare providers, but also from patient organizations. So we have done some research in quality of life in the MN1 population in the Netherlands, also because the data were very sparse in MN1 as well. So we did a cross-sectional study in over 200 patients with MN1, and we used the cancer worry scale, also used in the VHL studies, and the SF36 questionnaire, a more generic quality of life scale. And here we found that there was worse quality of life in MN1 patients in comparison with the general Dutch population. And there was quite some unawareness of the disease, but also about which manifestations patients had. So, for example, we found that some people didn't know they had a pituitary tumor, for example, or a pancreatic neuroendocrine tumor, which is quite shocking. But also quality of life was related to this. So if they knew they had a pancreatic neuroendocrine tumor, the quality of life was worse. So in this sense, ignorance is bliss. Employment, again, was a crucial predictor for quality of life. I think it was the main predictor for a good quality of life in the MN1 population. What we did is that we compared the cancer worry score, so the score of fear for disease occurrence actually, and we compared the MN1 population with VHL population, the Dutch VHL population, the familial adenomatosis population, the Leeuwaarde and breast cancer. And here we found that the level of distress, so they had the level of worry is highest in the VHL population, and followed by the MN1 population, which again stresses out that this is a very relevant topic for patients, and our patients experience a lot of distress and worry. So what could we conclude from our MN1 studies was that fear of disease occurrence was significantly associated with all scales of the health-related quality of life as a 36 questionnaire. High scores were associated with lower quality of life, and the more manifestations patients have, more fear there is for disease occurrence. And there was in general more worries about family members than worries about themselves. And I think this we can extrapolate to our VHL population. A study from the US also showed that financial burden was for a very important factor for quality of life in patients with MN1. And this is what you actually see across the MN1 population, but also in the qualitative study from Australia, as the financial burden has a real impact on the quality of life in our patient groups. So we recently did also a qualitative study in our MN1 and MN2 population, in which we are very interested in how do our patients perceive regular tumor screening, which we also do, of course, in our VHL population. 12 patients were interviewed, and here it shows that screening brings MEN to the foreground and may both exacerbate uncertainty, but also provide a sense of control over the disease in our population. And the patient stretched out that good care includes providing family-centered care, but also careful attunement to patients' needs within a good doctor-patient relationship. So I think this is very important, and we all invest a lot in our doctor-patient relationship in our hereditary tumor syndromes clinics. So all the studies I just showed, so we don't have a lot of studies on quality of life in VHL. Actually, these were the ones there are. But what can we learn from the studies? That the data are very scarce on quality of life in VHL. But there is significant fear and worry about the disease. There is impaired quality of life, and all the studies stretched out a need for more family-oriented psychosocial support, but especially the young age group needs attention and needs specific psychosocial support. So what are the challenges in VHL disease regarding quality of life research? So we all deal with small sample sizes. And that is, of course, a problem across the different topics, not only quality of life, of course. We have to also take into account the heterogeneity of the disease. So we have different age groups, we have different tumor locations, different type of tumors, and that's that we all need to take it into account regarding quality of life. Different treatments, and we know that subgroup analyses are quite difficult if the sample sizes are quite small. So we've been thinking, how can we address all these challenges regarding quality of life? So we started our Dutch prospective VHL registry in the Netherlands. So we have 8 academic hospitals here, and in 5 centers we treat patients with VHL. So we now have our Dutch prospective database, but we're also setting up our biobank. And when we started this registry, we also found that we should create a quality of life data bank, just to make sure that we have enough data about quality of life in our patient group. So that's actually included in the database, and annually patients will receive questionnaires on quality of life. And we have decided to also include the children, because I think that this age group is really, really important regarding all the problems they can face, also regarding their family members who can be ill. So we have decided to also include patients from a young age. And if we see what kind of questionnaires are used up to now in quality of life research in VHL, we see a lot of generic scales. Well, I've just summarized the ones that are used up to now. They're all generic. So well, the problem is that relevant issues are covered, but not all the unique experiences of VHL patients are captured. So a fixed set of items may not be relevant for every patient and may miss important patients reported adverse events, for example. Another poll question, because now we'll be talking about PROMs and PRAMs. Which statement is incorrect? Patient-related outcomes are assessed with PROMs. PROMs capture a person's perception of their health. PROMs capture a person's perception of their experience with healthcare. And health-related quality of life is the most widely used PRO. So which statement is incorrect? I don't see this here. I expect most of you know, but it's good to see, because we will talk about PROs now. PROMs. So I hope I can see the results now. Yes, I think most of you are correct. C is incorrect, because an experience with healthcare is actually a PRAM. Okay, so we can move forward now. We're on the same page now. So we decided to have an elaborate combination of different questionnaires, PROMs, the dark blue ones, but also a PRAM, but also the more disease-specific quality of life questionnaire, which is the ERTC brain tumor questionnaire, but also a quality of life questionnaire regarding visual function. But seeing all the different quality of life skills we wanted to use in our population, I was thinking we should do better. We should be able to think of something new, think of something that can address our patients' needs in one questionnaire. So I think that future direction should be that there should be a VHL-specific measure that meets the need of our clinical practice, our academia, our research, but also industry. A VHL-related questionnaire, quality of life questionnaire, which we can use in different areas. So how can we how can we set up a questionnaire? So we have some experience, of course, to develop new questionnaires. There is a static process of developing a questionnaire, which can take years. You have to generate quality of life issues, construct item lists, pre-test the professional questions, field testing to determine reliability, validity, but also responsiveness. So this is a static process, but there in the ERTC, there's also now a more flexible process in which you can combine a generic scale, such as the C30. I think most of you know the C30 quality of life questionnaire by the ERTC, combined with a more disease or site-specific module, but you can also use validated items from an item library. The light goes out here, so I have to move a bit. Yes. So there are item libraries. What is an item library? The ERTC has a platform of more than 900 individual validated items from 60 ERTC questionnaires. Also, the NCI has item libraries, for example, the items on toxicities, adverse events. And so by combining the generic scales and the individual validated items enables to cover the full range of issues really relevant to the disease. And what's also, I think, very nice about item libraries is that it enables the use of computer adaptive testing and tailoring the selection of items based on previous items. And it improves relevance for patients in answering questions that are meaningful for them. So if patients don't have any visual impairments, then they will go to the next questionnaire. It allows for shorter questionnaires, which also makes better compliance and to repeat questionnaires. And opens the way for longitudinal measurement. So what I already said is that I think that we should try to establish a health-related quality of life measurement strategy for our VHL patients, and indicating which issues should be used for all patients, but also for our subgroups. So that would be the first step towards VHL-specific pros in clinical trials. And I do believe regarding the sample sizes that it should be an international endeavor to achieve optimal sample size. So not only the Netherlands, but we should do this in an international work group. So that's actually what I'd like to propose, to have a VHL pro working group and to see how we can work on a VHL questionnaire for our patients. So if you're interested, please contact me. And this is a very nice painting. I think most of you probably recognize Van Gogh here with all the people working together.
Great, Rachel. Thank you for that talk. A very, very important work. I was going to ask you about the international endeavor, but I guess you would have to consider the variations in healthcare from region to region, which may impact some of the responses that one might receive.
Yes, exactly. And that's why I think that a flexible approach using like an item library, we can all select what we think are the main parameters to address in our patient group, because of course there are differences, but I think there are also lots of similarities. And in the ERTC, for example, a lot of questionnaires are already translated in all different languages, and this, I think, the way to move forward is to have all different languages already and develop one.
Yes, terrific. Raymond Kim has a question. Go ahead, Raymond.
Hi, Rachel. Good to see you.
Hi, Raymond.
I was very struck by, your therapeutic relationship that's so important for these patients. And I'll take a page from Dr. Billy Kim that I treat my VHL patients as if they were my own family too. And I think many of us do. But I wonder, I come from a very resource limited public system. And if we were to focus our psychosocial support on patients, do you think it should be early intervention on young patients that is going to prevent people from needing it later on? Or do you think it's going to be patients who have been affected with cancer or have tumors that are actively undergoing treatment that are going to need it? Or perhaps if we intervene early, they will develop the tools that when they encounter that cancer, they may not need as much support. So just trying to think, between our pediatric colleagues and our colleagues, adult side, where we could kind of mobilize these limited resources.
Yeah, so I think that what we find in the studies that have been performed is that the young age group is the age group with a lot of problems, impaired quality of life. And you can imagine that most of them don't really, some of them, of course, have manifestations regarding VHL, but a lot of them probably don't have lots of problems yet. What they see in their families, people might have already disease because of VHL, and in adolescence, for example. So I think that we should start collecting data also on how quality of life is from a young age, and see from the data how the quality of life is, and then offer psychosocial support. But I think that it is a challenge, but I think we should include all ages. We should include the whole entire population, especially because we have the small sample size. So I don't think we have we don't have the opportunity to say we're only going to focus on specific subgroups. We have to collect a big sample, and then we can make subgroups and see what are the specific needs for these different subgroups. I think that's the way to move forward.
Great, thank you, Rachel.
We have another question from Jesse Pasternak.
Hi, thanks so much. I don't know if you can see me, but it may not work. Really appreciate your talk. It's really awesome. You're obviously, the leaders in this area and other genetic issues. I'm one of the surgeons from Toronto, an endocrine surgeon, and I struggle with this issue a lot, especially around the perioperative management of patients with VHL and other similar types of hereditary diseases. One of the questions I had was something that has really revolutionized the care for these patients is, harnessing the internet and, social media and other types of support groups online. And I'm wondering how we can leverage that specifically in VHL patients, specifically considering, a lot of these pockets are scattered throughout the world, and we can, potentially use, this alliance and others to try and help with these supports. Have you looked into that and how we can do that, from all the way from Canada to the Netherlands and make these kinds of connections?
Yeah, I think a very interesting question. And I think that we all face with patients who look up a lot of things on the internet. But in the Netherlands, I don't know how, but most of them are directed to Rachel Giles, our chair of the VHL and the Alliance here. So they all have close contact with her. And I think that is very important, that our patient organization provide information to the patients. And if they go online, that it doesn't take a lot of time to go through the VHL Alliance or to the other patient organizations throughout the world. But that is something that's quite, of course, it's quite difficult. Actually, I was busy with my clinics while listening today. I had 2 new patients VHL, and they both came through our patient organization to my clinic. So I think it works. It really illustrates the importance of our advocacy groups. And patients find the groups and also are referred to us. So we should invest in that as well. I think also from the studies we find that support from the advocacy groups are very important. And luckily they are very visible on the internet.
We have one more question from Dr. Billy Kim.
Yeah, if there's time, be great. So number one, that was really nice and important work. So thank you for doing it. Something I don't think about routinely, but very important. It seems like there's clear documentation from your work and others that there's quality of life issues from having these inherited germline familial cancer predisposition syndromes. I'm curious what you think about the next steps. So like the next step to me would be like an intervention, right? So have there been surveys done about what people or qualitative work about what types of interventions might alleviate these distresses?
So no, we don't have the data yet. That's the problem. I think the first step should be longitudinal quality of life data, that we establish quality of life data banks and to see where the bottlenecks are in the patient journey, to address those bottlenecks. If we see around surgery, for example, or around childbearing, things like that, are these the times in patients' journey that we should address? And if we know where there are heightened levels of distress in those periods, then you should offer intervention, which can be a psychologist, for example. I work here with a nurse practitioner who has a very important task to always ask about psychosocial concerns in patients. As a physician, sometimes I don't have the time to really dive into that, because you're talking about scans results, talking about treatments, but not about psychosocial problems. So I think it would be important to see where are the problems, and if we do an intervention, I think more psychosocial support with psychologists. But first step is to see where are the problems, when are the problems there, and also to have a good scale, because you need a good scale to see where, what the problems are. And I think that is lacking now. A generic scale doesn't fit for our VHL patients. It just doesn't.
Yeah. All right. Thank you so much.
All right, thank you. Thank you, Rachel.